صباح الخير, السلام عليكم, يسعد صباحكم. This is the second day here. I'm really happy to be part of the SSRC family. So today I was given the task to talk about Raynaud's phenomena and digital ulcers, two diseases, domains of scleroderma that they interrelate, that I think you need to talk about both. One patient زي ما بنقول بالعربي يمكن يشيبك. It's very tough to treat those patients. This manifestation especially. Inshallah, I'll give you just a simplified overview how to manage those patients. So I have no financial disclosures, and I'll be talking today about. I'll share with you some case scenarios, primary versus secondary. We'll talk about the differences between primary and secondary. Just a couple of slides about nail fold capillaroscopy, treatment approach of Raynaud's phenomena, and digital ulcers. So let's start with a case scenario. This is a 25 years old young lady presented to the clinic with recurrent episodes of Raynaud's phenomena. Actually, that's her picture. And we know when you take a simplified history, there was just a white discoloration of the digits, stays for a couple of minutes, reversed by rewarming. She has no family history of connective tissue disease, no other clinical manifestations suggestive of underlying connective tissue disease, such as a malar rash, photosensitivity, and GERD or respiratory symptoms. And on exam, there was no scleroductally, pitting ulcers. There was no loss of the digital tufts, which also gives you a hint that there's an underlying pathology. And her labs were negative. And for reassure her that, you just need to lifestyle modifications and just close monitoring for any new symptoms. So let's just briefly talk about what's the difference between primary and secondary. There's a lot of nomenclature of primary and secondary, and this is one of the most simplified nomenclature, that symptoms occur alone without evidence of any associated disorder, or secondary refers to an underlying related illness. And if you look at the pathophysiology, I think there's major differences between a primary and a secondary, where primary is just mediated by alpha-adrenergic responses, whereas a secondary, there's a lot of underlying pathophysiology, as you can see. Here there's endothelial dysfunction. It's more a vasculopathy, what we name it. There's a lot of endothelin 1 and increase with decrease in the nitric oxide release or activity, and there's a more in-depth pathophysiological mechanisms that happen in secondary. So there's major differences even if we look at the pathophysiology. If we look at secondary causes, I mean, there's a very long list of secondary causes, and when we see patients in the clinic, I think this should be in our minds. We need to roll out other secondary causes. And I just highlighted ones that, sometimes we forget, such as hypothyroidism. I mean, it can give you that biphasic Raynaud's or monophasic Raynaud's. Malignancy is also something we need to look into. Middle-aged or, gentleman or somebody above the age of 60 with a new onset Raynaud's phenomena, we need to be aware that or alerted that there may be an underlying occult malignancy. And there's other causes. I think medications is one we always look into, and mechanical injuries and other secondary causes. Sometimes you screen, you look, you just tick the boxes, you look at all the causes, and you don't find anything. And there's this nice paper in 1990 that 54% of patients there is no cause. So sometimes you utilize all your methods of deleting or screening, but at the end you can't find any cause. So it doesn't mean that there should be something, but I think close follow-up and serial follow-up visits can help also with trying to elucidate if there's any underlying connective tissue disease. Let me share with you another case I've seen in the clinic. This is a 65 years old gentleman, past medical history of hypertension. He was on an ACE inhibitor, and he was seen by his cardiologist for joint pain and changes in the color of the skin of the hands. And the cardiologist went further, and he did some autoimmune workup, and it showed a positive ANA with centromere pathran and an ENA with a positive anti-centromere antibody. And at that time, he referred him to us in the clinic. He has a history of GERD. He was on a PPI. And when I examined him, there was puffiness of the hands, and there is some changes in the hands that suggest that there is recurrent Raynaud's phenomenon, which is mainly loss of digit tufts, but there was no digital ulcers. We did a nail fold capillaroscopy, which was abnormal, and given his age, and we diagnosed him with limited cutaneous systemic sclerosis, but given his age, there was, it gives you that red flag that there may be an underlying something wrong. Having Raynaud's at the age of 65, it's really alarming. So we did age and risk appropriate malignancy screening. We did an upper endoscopy, showed some chronic inactive gastritis. We did a colonoscopy, benign polyps. We did a CT chest abdomen pelvis actually, and we did a PSA which was abnormal. And he was referred to urology, and he underwent a biopsy which showed a prostate cancer, and he had underwent total prostatectomy. And I'm still following him up. I put him on hydroxychloroquine, and he's on Norvasc. So this is something you should just be careful of. So just for fellows and residents, I think Raynaud's is very important. Some patients they just declare that they have cold extremities when you ask them. I think it's sometimes good to show them a picture of Raynaud's. You need to have a line of demarcation. You need to have sometimes I share with them this picture. I just show them what's Raynaud's, because just cold extremity does not mean Raynaud's. But if you have Raynaud's, if you have scleroductal and DNA, you confidently can tell patients that they have scleroderma. Sorry. If absent, then you need to do a biopsy, and you look for secondary causes such as scleromyxedema, and other mimics of scleroderma. And if we look at this review article with hand impairment, if we look at Raynaud's phenomena, it's about 95% of patients will have Raynaud's phenomena, and digital ulcers in about 60% of patients. And if we look at our registry, 88.6% in the UAE have Raynaud's phenomena. Even we have this thought that because of the weather, patients do not have Raynaud's phenomena. I think this tells you that it's not only about weather, there's other factors that can contribute to developing Raynaud's phenomenon. And it's mainly more in diffuse, and then limited was about 82.6%. So this is the journey. Again, yesterday we showed this picture. This is the scleroderma journey, and you can see that patients can present, Raynaud's can present as early as in the beginning. It can be the earliest signs of systemic sclerosis. So I think we should be cautious when we see patients developing new onset Raynaud's phenomena. What are the phases? I think this is very important for fellows. There's 3 phases. There's the paler, blue, and red. And again, about 95% of patients with systemic sclerosis can have Raynaud's. About 60% have 3 color changes. Usually it's about 40, biphasic is about 14 to 40%. And that can affect the tip of the tongue, the nipples, and the earlobes. And sometimes patients, the only thing that they can tell you, that I have numbness and tingling in the digits. And this is maybe one of the earliest, even preceding having Raynaud's, that they're having recurrent tingling sensation at the tips of the finger. And if I want to be more alerted to which color, I think the blue is the most important color. The longer the bluish discoloration, the more it alerts me that there may be an impending, what we call an ischemic phase. And this is like a heart attack. So this is like, if it's more than 20 minutes, I think they should be referred to the emergency department as soon as possible. What are the clues that can give you that there may be, to suggest secondary changes in scleroderma-related disease, later age, patients more than the age of 35? I think this should alarm you that maybe there's a secondary cause. If they are males, it's more common in females. About 60 to 70% of females can have primary Raynaud's phenomenon, mainly monophasic, asymmetric attacks. If you find other features of Raynaud's phenomena, abnormal nail fold capillaroscopy is very important, and I'll just address this in the next slides. And these are very important points. Raynaud's phenomena associated with ischemic changes. If you have ulcerations, if you see pitting ulcers, if you see loss of digital pulp or tapering of the fingers, this would alarm you that there is a recurrence of the symptoms. Nail fold capillaroscopy, I think there was a workshop early in this conference, and I think, as a rheumatologist, I just want to make sure, is it abnormal or normal? I don't care about, other findings that sometimes we read about. As you can see here, usually it's more like a fine hairpin capillaries, but sometimes you see dilatation as shown in the picture. Sometimes you see microhemorrhages or giant capillaries, and this gives you an indication. And just for a clinical point, usually the fourth and the fifth digit are the best places where you can screen, because the skin is very thin at the base of the nail bed. It's a very important tool, and as you can see here, if this is different scenarios. If you have a negative nail fold capillaroscopy with positive autoimmune profile, what are the chances or the odds ratio of having scleroderma, and the odds ratio of, if just the highlighted odds ratio for developing scleroderma with a nail fold capillaroscopy that's abnormal is about 50%. So it's a good tool to use, just even to reassure patients. Sometimes if it's normal, you can reassure patients that it's very unlikely that you're having any underlying connective tissue disease. What are, in summary, briefly, the therapies that we recommend include the lifestyle modifications, and it works. About 65% of the time it can help. We'll talk about them. Calcium channel blockers, the nitric oxide pathways such as nitroglycerin paste, PDE5 inhibitors such as sildenafil, tadalafil, and other medications, ARBs like losartan, SSRIs, fluoxetine, an antidepressant, prostaglandins, epiprostanol, prostacyclin. I'm sure most of us, we use it, Flolan, we call it, endothelin receptor antagonist, and I put finally botulinum toxin and reflex sympathectoms. Let's just briefly highlight each one. Lifestyle modifications. There's a lot of wearing mittens, rewarming the core part of the body, especially the chest. Rewarmers. We see these days patients are buying rewarmers. Smoking cessation. Sometimes estrogen hormonal therapies can worsen Raynaud's phenomena. If we look at calcium channel blockers, I think this is one of the most common medications we use. Dihydropyridines versus none, such as dihydro, such as Norvasc or amphidipine versus diltiazem, and they work about 30% of the time, in addition to lifestyle modifications. Inexpensive, and they decrease the amount of the recurrence of Raynaud's phenomena by 4 per week. But they come with some side effects, lower extremity edema. You should be careful when using them in patients with pulmonary arterial hypertension, and they were not shown to effective for digital ulcers, even though we still give them. But the studies, and just a quick comment here. The studies in Raynaud's phenomena is similar to lupus. I mean, most of them are negative, so it's all comes from our clinical practice. PDE5 inhibitors, we use them as an add-on therapy. Usually we start with the calcium channel inhibitors. If in uncontrolled, you have either the option to switch or to add sildenafil, Rivatio, it comes in 30 milligrams, or you can use Viagra, which comes in 50 milligrams every 8 hours. You can split the pill to 25 milligrams every 8 hours. It depends on the tolerance of the patient. Tadalafil is another one we use. And again, as you can see here, some of them are positive studies, some of them are negative. Direct, indirect vasodilators. So these are all the drugs that have been in the market. Nitroglycerin, I use it commonly in patients. Can apply it to the inner aspect of the digit, especially of the threatened digit. Prazosin was also studied. I don't use it a lot. I think last year there was a case. One of the posters was in this meeting about prazosin with good outcomes. SSRIs, we use it also. Honestly, it's a good add-on if patients on a calcium channel blocker and you want to add on with, sometimes patients have this low mood or they feel low. I think it's a good add-on. ACE inhibitors was shown to be helpful, improving the blood flow. Angiotensin receptor blockers also. There was a trial about L-arginine, which was not beneficial. And there's others such as aspirin and Plavix and other thrombexin A2 inhibitors. And there's some studies about ginkgo biloba and vitamin E gel. So, botulinum toxin, we don't use it a lot. I have one patient that I sent to plastic surgery. You know, you need to have this also a good relation with the plastic surgeon. Not every plastic surgeon have an expert in such conditions, and it showed honestly a good benefit, especially in improving, alleviating pain. But it's also transient. I think they should have more than one session. But these are the sites where you can use about 5 to 10 units of Botox. Sometimes they feel hand weakness, in about 14%, but in this study it showed about 100% reduction and healing of ulcers. So it's one of the options that you can consider in refractory patients. And this is a very simplified approach. I think it's very useful to use in the clinic. It depends on the number of attacks. If it's less than 5 attacks, you go to the left side. You start with a calcium channel blocker. You add a PDE5 inhibitor, then you add an ARB. And it's sometimes very challenging to use this in the practice, especially with low blood pressure patients. So you need to be careful with hypertension. Sometimes you need to split the drugs. You give them one in the morning, one at night, just to make sure that they don't feel dizzy. And if you have more than 5 attacks per week, and then you go to the other route, the right one, and you have more options here. You can use botulinum toxin and reflex sympathectomy. I have one patient who had reflex sympathectomy. It was well tolerated. She felt benefit mainly in pain, but it didn't stay for a long time, maybe just for 6 weeks. So it's an option just to be considered in patients with refractory or a threatening, digit. Let's switch to digital ulcers. Very unmet needs in both Raynaud's, as Dr. Walid mentioned, Raynaud's and digital ulcers. And there's a lot of unmet needs in digital ulcers. It can result in infection, gangrene, amputation, and downstream it results in disability, inability to work, and reduction of the quality of life. If we see in our cohort the percentages of patients that had digital ulcers, alhamdulillah, it was 34%. It's very challenging. I'm sure all of us who have at least one patient, it's truly challenging. 34% and limited cutaneous about 15.2%. So we need more treatments. There's 2 types of ulcers. I think this is very important for fellows. There's something called ischemic ulcer, which comes in the tip of the fingers, and there's traumatic ulcers, which are more on the dorsal aspect of the hands. So usually most of the treatments, they consider ischemic ulcers more than traumatic ulcers. So when you are reading the studies, it's more highlighting or enrolling ischemic ulcer patients. So digital ulcers, we have endothelin receptor antagonists. We have bosentan. I have a couple of patients. Less? 1 minute? Okay. A couple of patients. It's well tolerated. Honestly, it's hard to get. It's hard to have an approval for the medication. But if patients tolerate it and they get the medication, it's very useful, especially in digital ulcers. You start with 62.5 milligrams twice daily for the first 2 to 4 weeks. Check liver function and increase the dose to 125 twice daily. IV iloprost, I use IV epiprostanol and prostacyclin. And so now there's something called the healing, and there's a prevention. There's a different approach when you treat digital ulcers. And these are the drugs that are approved for healing. These are approved for prevention. And again, we come back to this very nice paper by Janet Popp, where you can either whether you are targeting prevention versus active treatment. So this is just, I think this is the final slide. This is an approach how to treat a threat. And this is one of my patients, very refractory to all treatments. Been on nifedipine, Norvasc, bosentan, not well tolerated, some compliance issue. So I think the most important thing in such life-threatening digit is pain relief. I mean, pain should be 100% relief with the maximized painkillers that you can, PCA pumps, oxycodone, because this helps with the circulation. Antibiotics is very important. You need to start antiplatelet aspirin, aggressive vasodilation. There's something called reset phenomena where you need to maximize therapies, calcium channel blockers. You need to combine therapies. Actually, this patient was admitted. She received epiprostenol and the other, selective digital sympathectomy, botulinum toxin. Sometimes it's hard to do on the spot. You need to refer them. But the upper points are easy accessible as an inpatient. And sometimes if it's refractory, you need to do an angiogram of the upper extremity looking for a possible narrowing of one of the main arteries, such as the ulnar artery. And this is one of the protocols. I think, usually it's hard to know how to give the medication. We give epiprostenol, sometimes we give Flolan. And this is, if you want to take a picture of it, you can apply to your practice. And this is the final slide. It's a summary of all the current medications for Raynaud's phenomena and digital ulcers. And with this, I would like to thank you for your attention. Thank you very much.